Good afternoon, everyone. This is Dr. David Sperling from Columbia University, Department of Radiology. We will be starting in about 2 minutes. Appreciate your patience. Okay, I think we can begin. Good afternoon, everybody. My name is David Sperling. I am an associate professor of radiology at Columbia University Medical Center in the Department of Radiology within the Division of Interventional Radiology. I would like to welcome everybody to our Facebook Live event today. We will be talking about prostate enlargement and a minimally invasive solution that we can offer everybody. We'll have a comprehensive discussion about what prostate enlargement is, symptoms it may cause, treatment options, and hopefully we can give you a lot of good information here today. If you have questions about anything that we talk about, we would appreciate you asking those questions in the comments section on the Facebook Live. That way we can address them at the end of the talk, and there will be plenty of time to ask and answer questions. So with that all taken care of, I think we will just go ahead and begin. If this will turn, and let's see. Okay, great. So first things first, what is BPH? So BPH, for those of you that have it, understand that it is benign prostatic hyperplasia or a benign non-cancerous enlargement of the prostate gland. This commonly occurs as we get older. In general, if you are in your 50s, half of you have BPH. In your 60s, 60% of you have it, 70% in their 70s, 80% in their 80s, and 90% in their 90s. What does this mean? What this means is if you live long enough, you're going to get BPH. The good news is most patients with BPH do not have any symptoms, or the symptoms that they have are quite tolerable. And in fact, most people don't need treatment for an enlarged prostate. This talk is going to address those people that do need treatment for their enlarged prostate. So on the left side of the screen here, you see what a normal bladder would look like, and how the urine gets out of the bladder is, as you can see by the white arrows, the urine goes out through a tube. The tube is called the urethra, but it just so happens that the urethra passes directly through the center of the prostate gland. So the prostate gland, it does contribute some fluids into the semen for the ejaculate, things like that. But because the urine and the semen use the same tube, if you have enlargement of the prostate, as you can see on the right side of the screen, enlarging that prostate will then pinch the tube as it's coming out of the bladder. So if we are pinching that tube, you could only imagine how difficult it may be to get the urine out of the bladder. So what that ends up doing is causing symptoms. So the symptoms of BPH include incomplete emptying of the bladder, urinating more frequently, or having the urge to urinate very frequently. We know people that, have to pee every hour to 2 hours. We know people that go play golf and have to utilize the facilities, almost every tee box. So multiple times a day getting up from your desk, having to go urinate, very annoying, and we understand that. More symptoms of BPH include intermittency. So you start, you get out whatever you can get out, and then you realize that, there's more. So you start, you stop, you start again. This can happen multiple times for each time that you try to urinate. Urgency, we just talked about. A weakening of the urinary stream, so it just doesn't come out, fast enough, and it sometimes can just dribble out. Straining during urination. Some people have to really push hard to get the urine out, and some people literally need to push their own lower abdomen in order to squeeze the bladder a little bit more in order to get the urine out. And then the last one, which I think probably affects a lot of people in a very bad way, is waking up several times at night to urinate. The more people I talk to, the more people have this symptom. It can be anywhere from 1 time to 20 times a night. I can only imagine having to wake up even 2 or 3 times a night. You're probably exhausted the next day, and you're still exhausted the day after that, because every night you go to sleep, you have the same thing occur. So what you should know is that it's quite common to have these symptoms. We actually call these symptoms lower urinary tract symptoms, or LUTS, L-U-T-S, as an acronym for it. And even though in your 50s, 50% of men have BPH, only 15%, 15%, will actually have symptoms at age 55. However, at 65, when 60% of us will have BPH, 40% of us will have symptoms from the BPH. And then it sort of equalizes as you get older. 70% at 70 years old will have symptoms, lower urinary tract symptoms from BPH. How common are prostate-related procedures from BPH? There are well over 100,000 procedures performed annually for BPH. It is something that is extremely bothersome to patients, and they seek procedures and or medications in order to try to get those symptoms to be lessened over time. Who gets BPH and what causes it? We don't really know what causes it. What we do know is that the older you are, the more likely you are to have BPH, and the older you are, the more likely you are to have symptoms from your BPH. Men are much more likely to develop BPH if their father, brother, grandfather had BPH. So there definitely is a genetic predisposition for it. If you have a pre-existing condition like diabetes or heart disease, you are more likely to have BPH. And lifestyle, obesity does increase the incidence of BPH. Exercise actually reduces the risk of BPH. Yet another reason to exercise regularly. So what are the complications? Not the symptoms of having BPH, but actually the complications, right? You may have BPH. You may have some symptoms that are just not so bad. You may actually have symptoms that are bad, but if you wait long enough or too long, these things can actually occur. Urinary retention. Literally, you feel like you have to pee. You haven't peed in a couple of hours. Your bladder continues to get enlarged with urine, and you can't get the urine out. And there are people that end up having to go to the emergency room for this, have a catheter placed through the penis into their bladder for it in order to drain it. There are even some people who literally have to live with a catheter inside their bladder through their penis in order to get the urine out at all times, because they cannot at all get the urine out of their bladder on their own. Urinary tract infections can occur. Bladder stones, anytime liquid stays in a place in the body and it does not move, it is prone to, number 1, infections, and number 2, calcification and concretions, and those would be bladder stones, and those can be quite symptomatic. Bladder damage. If you continuously cannot get your urine out of your bladder, the bladder thinks that it needs to squeeze harder. So what ends up happening is the bladder muscle actually gets thicker, and it gets thicker still. And as it becomes more difficult, the bladder tries to get bigger. But what happens is that bladder wall thickening actually will prevent it from expanding up and allowing you to have as much urine in your bladder, and it actually will not be a stronger push to get it out, and it ends up being quite difficult and quite symptomatic. And one of the other things is kidney damage. So the kidneys produce the urine gets down into the bladder. If the urine can't get out of the bladder, then the urine can back up. If the urine is backing up, the problem is the kidney keeps on trying to make urine. But if the kidney does not have the capacity to place the urine into the bladder, the kidney says to itself, I can't do this, I have to slow down. So as your kidney slows down in functioning, your kidney function actually goes down. Worst case scenario, you may actually end up going into kidney failure because of this. How do we diagnose BPH? Patients are often diagnosed only when they have symptoms. When you do your annual physical exam with your physician, many times they do a rectal exam. When they do a rectal exam, what they're doing is they're checking for blood, number one, but number two, they're trying to see if your prostate is enlarged. A lot of people get PSA levels. PSA levels that's prostate specific antigen. And what that is it is a screening tool for prostate cancer, but it is also elevated in patients with BPH and in patients with prostatitis, which is an infection in their prostate. The presence of BPH is most often confirmed by either an ultrasound or an MRI. We can see sizes, we can see changes, and we can figure out, many times what's going on in the prostate with those imaging exams. And if necessary, if there are suspicious areas on the MRI or on the ultrasound, or if the PSA is just way too high for anybody to be comfortable, sometimes your urologist will end up doing a prostate biopsy, and that is utilized to make sure that you don't have a cancer in your prostate. All right, how is BPH treated? So first of all, we don't really treat non-symptomatic BPH, right? You really should have symptoms if you're going to be treated. And so the treatments, and we'll go over all of them, really depend on how old are you, what's your general state of health, how severe are your symptoms, and then we figure out which treatment plan is best for you in conjunction with either your primary care physician or your urologist. So we always like to treat people from the least invasive to the most invasive treatments. The least invasive is nothing. So if you don't have to get treated, that's great. If you do have to get treated, the next least invasive treatment is medications. Medications or drugs. There are multiple different classes of drugs that can be used for this. Some of them are hormonally related. They'll block some hormones, maybe they'll enhance some hormones. Some of the drugs have names like tamsulosin, dutasteride, finasteride, sildenafil, tadalafil. All of them, brand names I'm not going to go over, but if you're on them, you already know what you're taking. And the nice thing is they work, except when they don't work. So some of them they'll work, but they'll have side effects that are just unacceptable to you. These things include dizziness, drowsiness, impotence, decreased libido or decreased sex drive, and problems with ejaculation. So many men do not like to take the medications if they get these side effects. They can be tried on other medications, but one medicine has one side effect, another medicine can have another side effect. If you are taking the medications and they reduce the size of your prostate and they reduce the symptoms from your prostate, that's great. But if you stop taking the medication, usually the BPH gets back to the level that it was before and will continue to grow, and you need to seek out a different alternative for treatment. So those of you who have gone to urologists for your BPH probably have heard of multiple ones of these procedures. These are a little bit more invasive. In fact, some of these are the most invasive things that you can do for your prostate. You can have your prostate completely removed, right? A prostatectomy, that's what that's called. It's open surgery. Sometimes they can do it robotically. There are some procedures that are done through the penis, like a TURP. TURP stands for transurethral resection of the prostate. They'll carve out a little tunnel of prostate from inside the urethra. They can incise the prostate that way to make more room. They can actually microwave a portion of the prostate from the inside to try to kill a little bit of that inner portion of the prostate to make more space for the urethra to go. They can do thermal ablations, so they'll heat it. Sometimes they have lasers that are quite effective in lasering it from the inside out, again, trying to carve some physical space for the urethra to live inside that prostate. There's a procedure called urolift, where they'll go in and they'll place these like retention sutures, right? They'll actually put a needle through the prostate, and they have a bracket on it, and it literally like pulls the inner portion of the prostate open, so it's literally just like propping it open, so that way there's more room for the urine to come out. Resume is another procedure that many of you may have already tried. Water vapor therapy, they'll actually try to steam and kill some of the prostate from the inside. And then the last on the list is prostate artery embolization, which is relatively new compared to the other ones, but that's less invasive than almost all of those other ones that we were talking about. So, which treatment is right for you? We have to know if you have diabetes, we have to know if you have bleeding disorders. These are things that it's all going to depend on. Prostate size is a big deal. Smaller prostates can be treated a little bit easier. Bigger prostates, sometimes you have a limitation on which procedures you can use depending on how large the prostate is. And then one of the most important ones is you as the patient, your desire to avoid unwanted side effects of the procedures, such as. So these are a conglomerate of complications that can happen, or side effects that can happen from having any of the procedures. And I can go over for at least the prostate artery embolization afterwards in more detail. But the unwanted side effects include retrograde ejaculation. What that means is that when you ejaculate, the semen goes backwards into the bladder instead of coming out. Erectile dysfunction, you can't get an erection sometimes. Bleeding is certainly an issue with many of these procedures. Incontinence, temporary difficulty with urination. Some of these procedures require you to have a catheter placed through the penis into the bladder in order to assist in getting all of the urine out while you heal. And then urinary tract infections. What is an interventional radiologist? That's what I do. That's what my partners do. It's an entire subspecialty of physicians who are specially trained to do diagnosis and treatment of conditions using miniaturized tools. Typically, what I tell to almost all my patients is I'll pull out a pen and I'll say, we can do almost all of our procedures through a hole in your skin that's no larger than the hole at the end of your pen. And everybody needs to know that we've been doing embolization procedures for more than 40 years. This is not something that's new overall in general, and we're quite skilled at it, and it can really be a very, very good minimally invasive procedure for you. So what is prostate artery embolization? That's what we're going to talk about for the remainder of the talk. It is a minimally invasive treatment for BPH. It can absolutely reduce symptoms, shrink the prostate, preserve your ability to have erections, avoid surgery altogether, and does not come with many of the complications that we talked about on the other screen, which is retrograde ejaculation, really very little bleeding issues, very few unwanted side effects. The picture to the right is sort of a very nice summary slide as to what is an embolization. As you can see on the right, you have the red branching tubular vessels there. Those are the arteries that feed the prostate. So what we can do, the blue line that's inside the red, that is a catheter. Catheters that we use are about the size of strands of spaghetti. They have holes in them, so that way we can inject dye, and under live x-ray, we can actually make a map of all the blood vessels that feed the prostate. And once we know we are in the proper blood vessel that's only feeding the prostate, we can then inject these tiny particles. Those tiny particles are represented by this very, very small white circles inside the red. Those are made out of essentially plastic, and they are sized specifically to the size blood vessels inside the prostate. And when we inject them, they just wedge into those blood vessels and they block them. So by blocking those blood vessels, they're preventing any oxygen, any blood, any oxygen, any hormones from getting into the prostate. And by doing that, we're essentially starving and suffocating the prostate, right? So the prostate has no choice but to partially die off. And as it dies off, it shrinks. You still have some normal prostate, ability to function, but as the prostate dies off, it gets smaller, and as it gets smaller, the space coming out of the bladder enlarges, and it no longer pinches on the urethra, and you can then urinate more easily. Prior to anybody getting a prostate artery embolization, there's a little bit of workup for it, history and physical. We do like all of our patients to be seen by a urologist and to have attempts at treatment, at least medical treatment, if you need medical treatment, with a urologist. Some of the urologists will insist on a prostate biopsy if your PSA is really, really elevated. We get some imaging studies like an ultrasound, an MRI. Sometimes the urologist, very helpful actually, gets what's called a urodynamic study, where they will take a look, see how strongly your bladder is squeezing out the urine, seeing how much urine is left in your bladder after you urinate, and figure out, is this a bladder issue? Is it a prostate obstructive issue? Things like that. We also get some blood tests. So who's the best candidate for a prostate artery embolization or PAE? The larger the prostate, the better. It makes blood vessels bigger and actually makes it easier to do. And the largest prostates have issues with the treatment options that the urologists have for you. Pretty much when you get to the largest prostates, only open surgery is available. And if that happens and you have, let's say, some other issues like you have coronary artery disease, you're on blood thinners, things like that, a surgery like that can be quite bloody, and a procedure like a prostate artery embolization in that scenario can really just minimize all of the possible side effects, minimize all the complications, and minimize blood loss. Best PAE candidates, moderate to severe symptoms, right? We want to treat patients who are symptomatic because the goal here isn't actually to shrink the prostate, right? The goal here is to get rid of your symptoms. Now we do that by shrinking the prostate, but the symptoms are actually the most important thing. Anybody who's a poor surgical candidate, or people who are they just want to avoid surgery altogether. And we see patients every day who tell us that they just don't want to have surgery. And we agree with that, actually. If we could avoid it, we would avoid surgery too. Urinary retention patients. So if you are stuck with a catheter inside your bladder, that's somebody that really needs to have a procedure done, and the prostate artery embolization is a really good procedure for those patients. Also, if you have blood in your urine, now most people don't have blood in their urine with BPH, but some people do. And when you do, stopping the blood flow to the prostate actually stops the bleeding in the urine that's from the prostate. So that kind of makes perfect sense. Procedure itself, we can do it from two different locations, either from the wrist or from the groin. You can see the blood vessels and the pictures on the right side of the screen here. And as you can see, as you get lower down into the pelvic area, you can see the blood vessels branching and getting to the prostate over there. We do give you sedation during the procedure. It's conscious sedation, so you're relaxed. You don't have much pain at all. If you have pain, we give you more pain medicine, so we don't want you to be in pain. We do want you to be mostly a little bit awake though, because if we need you to hold your breath in order to take pictures to make a good map of the blood vessels that are feeding your prostate, we want to be able to stop the breathing, because as you breathe, it kind of makes the pictures a little bit more blurry. What happens during the procedure, like I said, we inject those acrylic embolic particles into the vessels that feed the prostate itself, just to block all the flow to the prostate. First, we do it on one side of the prostate, and then we do it on the other side of the prostate on the same day from the same puncture site. You don't have to come back to have it done twice. You don't have to have 2 needle sticks. It's all done through the same spot. Anything in the pelvis needs to be treated from both sides because they do share blood flow from one side to the other. What happens ultimately is the central portion of the prostate then scars down, is reabsorbed by the body. And like I said, as it shrinks from the central to the peripheral. So it opens up that space and does not pinch the urethra as much as it comes out of the bladder. Oops, sorry. These are representative images from an MRI of the prostate. This is quite a large prostate. Picture on the left, you're looking at it as if you are standing up facing, or it's that the patient is facing the person who's looking at the picture. So what you see in the middle there is like a orange-sized prostate with a lot of internal signal. That is just a very large prostate. And the picture on the right is shown from the side view. So on the furthest right portion of the screen, that's your tailbone. So your back is towards the right, your front is towards the center of the screen. And I don't know if you can really appreciate it. The bladder is white, right in front of the prostate. The prostate is this large sort of, avocado-shaped structure in the middle there. And the urine from the bladder is trying to get through the center of this, and this thing is just so large that it's not allowing it to go. These are images from an actual prostate artery embolization. The upper left-hand screen is a patient with our catheter already in the blood vessels. We do diagnostic injections as we are in those blood vessels to be sure that we're filling the prostate completely and that we're not injecting any of the dye into any other structures, right? We don't want it to go into the bladder. We don't want it to go into the rectum. We don't want it to go into muscular beds, and we don't want it to go into the penis. So we actually do a lot of different views and a lot of different injections to get them in there. But once we're satisfied that we're in the proper location, we inject those particles. Particles get wedged in there, block the blood flow to the prostate, and it starts working. Up and to the right, that's actually an angio machine with pictures on a screen. And we are actually performing procedures here. And as you can see, no cutting, no blood. This is just little needle sticks and small tubes and small caliber wires. After the procedure, you do recover in a private room. This is an outpatient procedure. You go home the same day. There's no reason to be hospitalized after this. You go home with a Band-Aid. There are no stitches involved. There's no incision and wound care involved. It's literally, we hold pressure. We use a small device to stop the bleeding at the groin or at the wrist, and you walk out of there. You might have a little bit of lower pelvic pain for the first day. Honestly, in our experience, I'll send patients home with a big bottle of narcotics that they pick up from their pharmacy. And most of the time, 2 weeks after, when I see those patients in follow-up, they tell me maybe they used 1 or 2 pills and that was all they needed. Most patients can go back to work in 3 to 5 days, and we do see you after, and we do measure your prostate after. We want to monitor how you're doing, and we want to see if it's possible to get rid of your prostate medications that you're taking, or at least that we know we've got you in the right direction where your symptoms have gotten better. For the first anywhere from 3 to 7 days after the procedure, you can have what's called post-embolization syndrome. Post-embolization syndrome happens because we're killing a portion of the prostate, and as we kill portions of anything in the body on purpose, we release some hormones that cause the body to react, and the body is reacting with a little bit of pain, a little bit of low-grade fever, maybe up to 100, 101, nausea, vomiting, sometimes diarrhea. And these are things that we know, we expect, we discuss with everybody, and they go away by themselves or with, ibuprofen, acetaminophen, medications like that can really help with that. Non-target embolization, I talked about before. We do not want any of the particles to go into the rectum or into your muscles, because if they do, they can cause complications and side effects, including pain, including some bleeding. So we always talk about that with patients. That's why you have the procedure done by people who've done a lot of these, so that way they can recognize what's going on, where your catheter is, and where it's safe to do the procedure and where it's not. Skin burns from the live x-rays that we use. If the procedure takes way too long, sometimes you can get a little bit of redness and what we would call a radiation skin burn. It is very rare for that to happen. We monitor the amount of radiation that we're using while we're doing the procedure. You can get a little bit of blood in the urine, semen, or stool. That does happen. Most of the time it goes away by itself and there's nothing that you need to do for it. Bladder spasm, hematoma, or like a little bit of black and blue and maybe even small nodules under the skin at the puncture sites. Urinary tract infections can happen, and urinary retention. Because we are attacking the prostate, right? There's a lot of inflammation that can happen immediately after the procedure. If you're one of those people that were teetering on the edge of not being able to get the urine out, you can actually get urinary retention short term after the procedure that can be fixed easily. Results in the literature, there are more than 40 articles that highlight the following benefits from prostate artery embolization. Significant improvement in the International Prostate Symptom Score. We have everybody fill out this IPSS. It's a survey talking about how many times do you wake up at night in order to go to urinate, how bad is your urgency, things like that. We do it beforehand, we do it after. Almost everybody has improvement in their symptoms based on the IPSS score. Improvement in your urine flow, how quickly it gets pushed out. Reduction in prostate volume, especially in the large prostates. There have not been any reports of prostate artery embolization related erectile dysfunction or retrograde ejaculation. The risk of urinary incontinence, while it can happen, is exceedingly low. 1 year after prostate artery embolization, 90% of patients treated have improvement in their symptoms, and the average prostate size is reduced by 30%. This is very important. I said it before, 30% reduction sounds great. I don't really care about the 30% reduction, right? Because the only thing that matters here is the 90% of people who have improvement in their symptoms. The 30% reduction is good, and we can follow that going forward. The symptoms are by far the most important thing. So overall, it's a 90 to 95% technical success rate of doing the procedure, 85 to 91% of patients with improvement in lower urinary tract symptoms, and 30% decreased size of your prostate. Very low blood loss, few complications, a completely outpatient procedure, and patients return to normal activity in about 1 week. We get a lot of questions when we do the consultations. Happy to answer them. We can go over a couple of them here. Will my symptoms completely disappear after prostate artery embolization? The answer is it can. It depends on where you start. If you start in the severe category, you're probably going to still have some symptoms, but they will be significantly improved after the procedure. Can I still get an erection after prostate artery embolization? We, in the literature, in those 40 papers, they did not say that anybody ever had any issues with getting erections after this procedure. Will my ejaculation be normal after the procedure? Again, we do not have any incident of retrograde ejaculation or the ejaculate going backwards after this procedure. Is the procedure done in a hospital? It can be done in a hospital, it can be done in outpatient offices. As long as the facility has the proper equipment installed, it can be done in either of those two. The most important thing to remember is, regardless of where the procedure is done, it's an outpatient procedure and you're going to go home the same day. Will I have pain following the procedure? A little bit of pelvic pain that really only lasts for a day or two is the norm. We do give you pain medication for afterwards, and in talking to all the patients that we've done, it's quite tolerable. Can I stop taking my medications for BPH with lower urinary tract symptoms after the procedure? Some patients can. We like to do this in concert with your urologist, and it is possible that you can definitely it's possible that you can get off of your prostate medication after. But if you can't, maybe you can just go to a lower dose. If you didn't like the side effects, maybe at least at that lower dose, you won't have the side effects from it. And I think that there's real advantages in terms of physically making the tube more open for you to get the urine out, and shrinking the size of that prostate that can really lead to discontinuing some of your medications or all of your prostate medications. Is PAE a safe procedure to schedule during COVID-19? It's perfectly safe to do during COVID-19. In fact, that's why we like to do this, and we're trying to do this now in our outpatient facilities so we can actually avoid having patients come into hospitals, because that's a fear that everybody has. We don't want to go into the hospital because of COVID-19. We totally understand that, and we are working to get this done in as comfortable an environment that patients will be happier having their procedure done. Will my insurance pay for the prostate artery embolization procedure? Most of the time, yes. We do get prior authorization for it. And if we have issues with the insurance company, we have a whole system involved where we will call the insurance company, make appeals for it, and make sure that we can afford to have everybody get the procedure appropriately with the cooperation of their insurance. So that's the end of the talk. We are here to help if you're suffering from symptoms from BPH, or if you suspect you have it, hasn't been proven yet, but you have symptoms like we talked about. We're happy to set up consultations. We can do most of these consultations by video visit. The phone number to call is 212-326-8874. Our website is www.columbiaradiology.org. Instructions are on there. Ways to make appointments, and phone numbers are on there as well. We have locations in Tarrytown and Westchester County, as well as in Midtown Manhattan. We have the main medical center in the northern part of Manhattan. So, we have a lot of availability. We have a lot of our physicians who are quite skilled at doing these, and we would love to be able to at least discuss the procedure with you and answer any questions that you have. So again, thank you so much for your attention. I have some Facebook comment questions. The first one that I'm seeing is, does the plastic microballs have any long-term issues, as in immunologic responses or chemical interactions? The answer is no. They are inert. They don't react with anything. They wedge into those blood vessels, and then they can't really go anywhere else. They can't go backwards and go somewhere else because the blood flow and the blood pressure is keeping them wedged in place. And in our experience, I have not heard or seen anybody having an immunologic response or a chemical interaction due to the plastic embolic spheres. Next question I see from Facebook is, how effective is the procedure comparison to doing the surgery? Good question. I mean, we did talk about some of those numbers. 86 to 91% of patients have reduction of symptoms. That's what success is. The success rates from the surgeries, I would actually defer that conversation to your urologist, because it really depends on what procedure they choose to do, what your medical comorbidities are, how risky is it for you to do, how big your prostate is, how little your prostate is. And then, of course, even with success rates, you still have to take into account the complication rates as well. Next question from Facebook. Can you have this procedure after you've had a urolift? Fantastic question. I've never done the procedure in somebody who's had urolift before. The issue that we may run into in a patient who has had a urolift is that there is that foreign material that's sitting in the prostate. And if we kill a portion of the prostate, I fear that there may be infectious complications that can happen in the prostate. It's a great question. I'll actually do a little bit of research on my own and see if I can get an answer for that one. will I have to be put to sleep for the procedure? We use conscious sedation for the procedure. Conscious sedation, like I said, keeps you very relaxed. A lot of patients are sleepy during the procedure. We give pain medication during the procedure as well. Some patients fall asleep, but they're easily arousable. So we can just shake them or just ask them to, hey, can you please hold your breath for 10 seconds while we do this set of pictures? Most patients are able to just hold their breath, and then either they'll close their eyes, go back to sleep, or they're at least just relaxed on the table and very comfortable. Another question from Facebook: are there any statistics on how many patients are able to discontinue medications after this procedure? The answer to that is no, but after approximately a month after the procedure, if you've had significant improvement in symptoms, it's not unreasonable for everybody who has improvement in symptoms who are on medications to attempt, in conjunction with their urologist, to reduce or eliminate one or more of their prostate medications. I do not see any other. Oh, wait, here we go. One more. My urologist seems opposed to me considering embolization for my prostate. What should I do? This happens almost every day when we see patients. We like to do this procedure in conjunction with our urologists. We think that we are partners with your urologist in your care, and we want to do what's best for you. If your urologist is opposed to it, you got to find out what's the reason why they're opposed to it. And if you know the reason why they're opposed to it, you can always have a consultation with the interventional radiologist, present what that opposition is, and we can either have a nice conversation about it. Sorry about my light. We can have a conversation about what the truth is. A lot of times, a urologist who maybe is just unfamiliar with the procedure will say, well, your prostate's too big, you can't have it. Then we can say, well, that's actually the opposite of true, right? The bigger the prostate, the easier it is to do the embolization. If they say, well, it's too new, so I wouldn't want that for you because it's a new procedure. The fact of the matter is, I did my first prostate embolization in like 2002. It's new in the grand scheme of things, but it's 18, 19 years old. The 40 papers that are in the literature account for approximately 10,000 prostate artery embolizations that have been done. So, new relative to, dinosaurs. Yeah, it's new relative to dinosaurs. But, while it's a newer application of embolization, we've done embolizations for many, many different modalities and many different diseases, and it works great. And we think that this one works great. How painful is PAE? Like I said, minor. For a couple of days after the procedure, you might need 1 or 2 pain pills, but for the most part, people tell us that it's really very, very easy to tolerate with minimal pain. Does an enlarged prostate ever shrink on its own? No, that was an easy one. How do I know if my prostate is enlarged? Well, if you have symptoms like we discussed, you should probably get evaluated for it. If it's not enlarged, that's great, but it means that it may be something else that's causing the symptoms. So again, it's a good conversation to have with your internist or your urologist, or with us. You can come, we can do those evaluations for you as well. I think I've run out of questions, unless our Facebook guys have any more. Okay, I think that really encompasses everything that we were going to talk about. It looks like there are no more questions through Facebook. It doesn't mean that you don't have an opportunity to ask more questions. So in other words, if you like, private consultation with one of our interventional radiologists. Like I said, here are the ways to get in touch with us. The phone number is there. The website is there. You can find us on the Columbia Doctors website as well. So ways to get in touch with us are very easy, and we encourage you to call us. And like I said, video visit. You don't have to leave your house. Private, and I think we can answer any more questions if you didn't have them here today. Thank you so much for your time. We know your time is valuable, and we really appreciate that you spent this lunch hour with us today. Thanks very much.